A hip fracture is the most serious consequence of falling, and it gets worse as we age. Over 90% of hip fracture patients are over 65 years of age. The broken hip tonight, on call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. When a small child falls, they often start laughing and are none the worse for wear. However, when those of us with more years behind us fall, it can be a devastating injury. First, let's take a look at this week's Prairie Doc Quiz question. List 3 different types of medicines whose effects might increase an elderly person's chance of falling. 3 medicines causing falls. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We answer your medical questions about bone fractures or orthopedic surgery, or your comments as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225, or send us an email to the address on the screen. Joining us tonight are Dr. Mark Mayer with Avera Medical Group Specialty Care Brookings, and Dr. Matthew Blake with Avera Orthopedics, Sioux Falls. Thank you, gentlemen, both for joining us. Thank you. Filled in. Someone was sick, and thank you for coming at the last minute.
Great
Mark.
opportunity.
That's great. Well, we're talking mostly about falling and hip fracture, but we can talk a lot about anything. But let's hear a little bit about each of you. Let's start with you, Matt. You are from where originally?
Originally from South Carolina, so I'm a transplant to Sioux Falls.
So, and then you did training where?
I did my medical school training in South Carolina, in Charleston. I did a orthopedic residency in Richmond, Virginia. Then I did subspecialty training in shoulder and elbow surgery at the University of Pennsylvania. And then I did further training in sports medicine at the University of Kentucky.
So you're kind of a southeastern boy.
I am a southeastern boy, so if I say y'all a little bit, just be okay.
Well, I trained in Georgia, and I always say that I'm from southern Dakota. So there it is. We like South Dakota. This is a great state. I believe you're going to be overwhelmingly in love with this, but you need to kind of go through a couple seasons to kind of realize the value of it. So Mark, you're from where originally?
Southern Michigan. I went to school in Central Michigan for my undergrad and grad in physical therapy, which was in the middle of the Lower Peninsula.
Oh, you were going to be a physical therapist?
Yep, I trained as a PT, and then I went to medical school after that. And then
did that help you for your training?
It did, but it was more debt for sure.
Yeah, more debt.
and 3 extra years, but it's very valuable now on the other side of it. And then I did my med school in Detroit, Michigan, and then my residency at William Beaumont Hospital, which is in a northern Detroit suburb. And
that's interesting. And William Beaumont was who?
I should know that. I think he was an Army general of some sort. No?
I don't know. I don't know. I was thinking he was the guy who they put who had a gunshot wound to his gut, and they put a window to his stomach and did all those studies. But that wasn't him. I think William Beaumont was a general. I think.
Okay.
Why are we doing So let's just talk about, you are now in Brookings, and we have robotic surgery in Brookings. Yes. Tell us about what you're thinking on robotic surgery.
Yes, so I practice general orthopedics, so I take care of a lot of different things, whether it's accident related like hip fractures, ankle fractures, carpal tunnel syndrome, meniscus tears, arthritis. I specifically came to Brookings because I was looking to do robotic surgery. Where I was at back in Michigan, I'm more of a smaller town guy. I grew up in a small town and on a small farm. And I saw this technology and thought, I got to have this for my patients. So I was actually driving 2 to 3 hours each way, depending on traffic, to be able to do surgery using the robot at another facility. But after about 14 months, that became old.
Yeah, I'm sure. Well, now you have, what, about
5 minutes.
Yeah. Isn't that amazing? One more reason to be in South Dakota,
That's
actually,
right.
I think so. And your field is shoulder, Matt. You are a shoulder and elbow expert, right?
Correct.
Tell us about that.
Yeah, so a couple great things about shoulder is there's a lot of different pathology that can happen in the shoulder. I see a lot of people who have problems with their rotator cuff, either inflammation of the rotator cuff, inflammation of the tendons about the shoulder, or tears about the shoulder. I see some people who can't raise their shoulder anymore, raise their arm above their head anymore, so they have a difficulty getting into cupboards and combing their hair and doing regular activities of daily living above their head. And there's different things that we can do to help restore their function and decrease their pain in their shoulder.
So, I mean, but you do hips and you do hips too. I mean, that's an interesting thing. Across the country, we know that in certain towns in Texas, they do a lot of back surgery, they do a lot of knee surgery, they do a lot of shoulder surgery. And in another town nearby, they do very little of that. And yet they look at the evaluation of back pain in the town, it seems to be the same. It costs the insurance companies a whole lot more in that first town, but there's universally, everybody does the same amount of hip surgery per capita. Yeah, and that's because, why?
People fall.
People fall, and uniformly, it's a comfort measure, really, isn't it? I mean, it's otherwise they lay in bed until they die from a blood clot, often.
Right. Yep.
Explain that. Why?
So, when somebody breaks a hip, I think, the recent research says fix it as quick as possible, get them seen by a medical doctor. I prefer to get them into the operating room within 24 hours because that is going to optimize their outcome. People with hip fractures have a lot of comorbidities, heart disease.
Comorbidity means?
Like diabetes or heart disease or COPD. They have a lot of other things, and if they're laying around in bed, and if you have a hip fracture, you can't get out of bed, you can't move.
Everything else goes worse.
Yep, you're going to lose muscle mass very quickly, you're going to get pneumonia, you're going to get a blood clot. So to optimize the chance of a recovery, fix it quick, get therapy working with them, and that'll optimize their outcome.
So fixing it quick oftentimes is just a pin. I mean, I'm saying just a pin, but that's a complicated deal. But it can be a lot of other things too, can it?
Correct. There's multiple different procedures you can do to quote-unquote fix a hip. And it just depends on the type of fracture or the type of broken hip you have. Sometimes it's simple as putting 3 screws in the hip to get them moving. Other times it's one big screw. Other times it's a partial hip replacement. And with each of those things, people are able to get out of bed easier, usually on post-op day 1, in other words, the day after surgery, and try to get up mobilizing again so they can return to life.
Right. So mobilization is the big key. I mean, you both pointed that out. I mean, the sooner they get moving, the better. I had a patient who had a hip replacement done pretty early. Lady was not that sick. She was in her 70s, healthy otherwise. And the cardiac arrest code was called, and we ran to the room, and she was gone. She died. And we had done everything right, and we had used anticoagulation as we could. There's that big question about how much anticoagulants you use. And when on autopsy, they found a great big saddle embolus, which means that a big clot flipped, and it landed right where it bifurcates to the lungs, and it stops any blood flow to both lungs, and she just killed her. And it's one of those complications that can occur, and you want to do it. That's the reason you want to do surgery early. What other problems can happen with surgery? If you do a pinning and you think it's the right thing to do, and then 6 months later there's arthritis, Mark.
So one of the issues is when you fix a fracture, you line it up, you always have to worry about protecting the repair. So you might have to limit the weight bearing on it, because if they put too much weight on it too early, then that could cause the fixation to fail, because this is usually osteoporotic bone.
Thin bone.
Yeah, weak
Right.
bone, brittle bone. On the other hand, when you have somebody who you do a partial hip replacement, which is for a different type of hip fracture, they're kind of 50-50. You have to worry about things like dislocation and getting an infection into the joint. So each one has their pros and cons, but it's very serious, and it's multiple dimensions on how to optimally take care of these patients. You got to watch the blood thinners enough to prevent clotting, but not too much to cause bleeding into the joint and get an infection as a result of that.
That's a big rub. How much blood thinner, what's the standard blood thinner protocol now for a person with a hip fracture? Is elderly, multiple comorbidities, multiple other medical problems? What blood thinners do you do on a person who gets a hip pinning?
I think it depends on a lot of their other, like we've talked about before, a lot of their comorbidities. What other medical conditions do they have? There's some people who they say, you know what, mobilization is number one, trying to get them moving. Second one is mechanical devices to help the patient circulate their own blood flow. So things that you put on their legs or on their feet that squeeze their legs and the feet to help circulate the blood so blood clot doesn't happen. Right now we're really trying to figure out what the consensus is on that. So some people say, okay, aspirin is good enough.
Yeah.
Other people say, okay, we need a little bit stronger, maybe Xarelto or Lovenox or Coumadin.
Or low dose heparin.
Or low dose heparin. And I think the majority in the orthopedic field say you need to do something, but we don't know what's the best as of yet.
Yep.
I mean, and you would think because there's so many hip fractures done every year that we would have a consensus.
Right.
It sounds exactly like what we were thinking 10 years ago. I mean, it's exactly what 10 years ago we were still struggling with that. I mean, we had come to the conclusion you needed a blood thinner.
Yes, yes.
Because people were flipping those clots, but the answer is, if you put them on a blood thinner, then they bleed into the hip. Then they have a big hematoma or a blood clot that's around the apparatus. That can raise the risk of infection. I mean, you come see, come saw, half a dozen of one and 6 of the other. That type of thing.
Yep.
So take-home message on hip fractures. What can we do to prevent them, Mark?
I think trying to take some precautions, if it's icy outside, don't go outside.
Yeah.
See your primary care doctor, get your bone density test done, when you should. Certainly people who are elderly or postmenopausal are at higher risk for that. So getting a DEXA scan done, looking at vitamin D levels. You can eat a proper diet all day long, but if you don't have the vitamin D in your system, it's not going to do you any good. So
if you're low on vitamin D, the vitamin D supplement of 2,000 is a great amount. If you're high on vitamin D, if you're normal in vitamin D, will 2,000 of vitamin D hurt you?
I don't think so.
No. I take vitamin D every day, 2,000 units, international units. Any other comments about fall prevention?
I think with fall prevention, if you've fallen once and have had a fracture, Avera has a great system in place to help increase your bone density so that it doesn't happen again. And there's different providers and different people that you should go and see to get, once again, bone mineral density checked and then also treated. And because that is bone health after one fall, you need to have bone health so that doesn't happen to you again.
Okay, but as an old internist, I'm going to add that there is no question about it. The very best bone density strengthening agent, without a doubt, it's exercise. Way better than any pills or shots or anything at all. Boy, if we can just get people to spend 30 minutes a day of walking, they'd get 99% of what good you can get from any of that.
Yep.
A hip fracture is a significant event at any age. There is a sequence of fracture, repair, rehabilitation, and recovery in order to be able to walk and live a normal life again.
When I was about 12 or 13 years old, I went on a school trip with my class back home in Russia, and we went on a climbing wall. And as I was climbing my distance, the carabine that attaches to me, it broke. So what happened is that I fell on one of the spots, which was a concrete floor basically, and it was just a sudden flop. After I got admitted to ER, they decided to do several different tests and x-rays. And what the x-rays showed that my elbow was broken, my pelvic bone was broken, and as well as it was dislocated. So what you can see when the bones get in, one of my side, which was my right side, was moved like this. So it was pretty horrifying to see, and it hurt a lot. After I got diagnosed, I got admitted to a hospital, and I was there for about 3 months or so. What my journey consisted of is I was laying down in a pose, basically just straight up with one of my legs open wide like this, and I couldn't move. So what I couldn't do is I couldn't sit, I couldn't turn, I couldn't get up, I couldn't walk, basically nothing. So I had to lay in the position flat like this for about 2.5 months. So once I got home, that's when all of my physical therapy and all of my recovery started, basically. I finally could start at least sit up and finally could normally eat or, at least take a proper shower. Since I technically couldn't go to a hospital to do any physical therapy, so a person would come to my house directly and then give me a massage on my muscles and my hip area as well as my back, because all my muscles were basically not used for 4 months and they were like in really bad shape. So they wanted to prepare me so I could start walking again and doing just daily activities. So what happened after that, I had to finally start learning how to walk again. So I started off with crawling. That was like kind of to get my hip bones moving and get that muscles build up, because it really helps you. So I did that. I crawled around my house, and after that I tried to learn how to balance myself again on both legs. So I would stand near the wall and try to push myself and hold it on both legs so I could have my both weight kind of balanced out. And obviously learning how to walk again was kind of a big challenge, because you feel like a little baby again. You don't know how to walk, you need help. I need someone to be there for me, to hold my hand, and kind of like even walk me through my house from my bedroom to kitchen just to eat or go to the bathroom. So no matter how young or old you are, think about taking care of yourself, and think about if you get injured, take care of your bones, take care of your health, and as well as do physical therapy. Don't lack on that, because later in life it will help you.
That was a beautiful video and a beautiful woman, Sophia, who is our field reporter for On Call with the Prairie Doc, and it was a joy to have her. We were saying, who do we know that has had a hip fracture that we could highlight? I did. So thank you, Sophia. She's from Russia. 3 months in bed from a pelvic fracture is what it looked like. Would you agree with the care that was provided? Well, I think we can criticize the way that they did that 12, 15 years ago in Russia. Would you do it differently?
For sure. If I saw a pelvic fracture like that today, there's special orthopedic surgeons, orthotraumatologists who fix pelvic fractures all the time, and you would use plate and screw constructs so that you can get them moving. But laying in bed hooked up to traction, that's more 1970s, 80s kind of care.
And kind of dangerous for blood clots.
Yeah.
So women, young women in particular, have risk for blood clots. What about elderly with a pelvic fracture? We usually just log rolled them and got them moving as soon as we could and didn't do any surgery on them. Would you do anything different on that, Matt?
Usually not. Usually the elderly people who fall down and have a pelvic fracture, usually it's a stable fracture. In other words, the pelvis is not going to move or shift on that individual, and so we usually get them up and moving right away.
So if, Sophia, if we would have had you here last week, we would have shipped you off to a pelvic fracture surgeon, get a plate put on, and then have you back for the show. We did get an email answer for your information. William Beaumont, born November 21st, 1785 in Lebanon, Connecticut, died in 1853, St. Louis, a U.S. Army surgeon, the first person to observe and study human digestion as it occurs in the stomach. So he was the surgeon who found the French trapper who had a gunshot wound to his gut. Okay. That's how it went. Okay. That's the guy who did it. This is your show, and your questions are key to our show discussion. Please, we love your questions. Call in about fractures of the hip or your experience in orthopedic surgery of any kind, or any orthopedic question to 1-888-376-6225. Or send us an email to ask@prairiedoc.org. Give us your call. So, but digestive surgery is probably not what we need to talk about today.
No.
So I'm going to throw you a question about the other surgeries that you do, or the common problems that you see. You see kids' shoulder dislocations in swimmers. You see fractured, what is the most common fracture? Is it women falling forward and breaking the wrists?
Yeah, I mean, that's very common. Hip fractures, wrist fractures, those are very common. Ankle fractures, those would be the most common type. If you added onto that some compression fractures like in spines of older patients with osteoporosis. But I see a lot of fracture stuff, see a lot of carpal tunnel, a lot of meniscal tears, a lot of arthritis, rotator cuff tears.
Yeah,
You know,
you see
everybody's
everything.
got those.
Oh yeah, right. So I think about the common ankle strain. That's a big dilemma. People twist their ankle. Matt, when should a person come in with a twisted ankle? And then what about the treatment that we've been providing with ankle stirrups for 1,000 years? I mean, I've got a couple sets at my own home. I mean, what about ankle stirrups and what do you do for a twisted ankle? What can we tell our people out there?
I think the first thing to do for a twisted ankle is you need to ice it. You need to get the swelling out of it. You need to ice and elevate. If you can take an anti-inflammatory medication, an ibuprofen, or an Aleve to help get the swelling out of it so you can start moving the ankle better, I think that's fantastic.
All right, so that's ice. Stabilize it, don't move it, right? Compress it with maybe an ACE wrap.
Yes.
And put and elevate it. So it's ice, compression, elevation, ICE.
Yes.
Okay, so then what happens? So the next day you try to walk on it.
It's still not feeling well, and you're hobbling around, and it's miserable. And I think that you should go and see the physician to see what's going on with it. There's some people who have twisted their ankle, twisted their ankle, and it's just an ankle sprain. The ligaments around the ankle get pulled. There's other people who have the same injury and the bone's broken. And it's sometimes very difficult without an x-ray to know which is which.
So there are protocols though that you can do to say when you should x-ray that ankle. I mean, Montreal protocol or something like that? I can't remember.
Yep, Montreal protocol, it's weight bearing. If you're able to weight bear on that leg, then usually that's just a sprain or a strain of the ankle. However, if you can't place weight and walk on it, then
You better get in.
You better get in.
And it isn't wait until tomorrow. It is get in right now. I mean,
Yes.
you lose a day, right, if you wait too long. And then what happens if it is not fractured? Okay, but you were having some pain. What do you do then?
I usually like to stabilize the ankle. The ligaments of the ankle have been sprained or pulled. I like to get that nice and stable. So you can do it many different ways. You can do it like the horseshoe ankle brace like you were talking about. You can do it with a lace-up ankle brace. Just any thing that you can do to stabilize the ankle. I usually get them on crutches and let them start weight bearing as their pain allows.
Yeah, that was what I used to do when I was working in the emergency room. You know, of course, that got taken care of by somebody who always works in the emergency room, which I thank the Lord for. Working in the emergency room is very challenging. That's the hardest spot. So, and you're oftentimes called to the emergency room. What do you see in the emergency room?
Usually fractures, so when people get injured, the ER doctor will evaluate them, usually get x-rays. And if there's a fracture that needs to be evaluated, I'll look at the x-rays. If it needs to be reduced or set in place, then I'll come into the ER and set it, put it in a cast, and then see them back and follow up.
So casts can be wonderful things, but sometimes they're too loose and they don't stabilize it, and sometimes they're too tight and you lose blood supply. Tell us about casting. How do you handle it?
So with a fracture reduction, basically, like a wrist fracture, I had a patient a couple weeks ago where she had neurological symptoms because her fracture was so displaced.
In other words, she was numb.
Yeah, her median nerve was affected, so she was having tingling in her nerve distribution there. So I reduced the fracture, planned on fixing it a few days later once the swelling went down to reduce the risk of a wound problem. So after I reduced it, her neurological symptoms resolved probably within an hour. But you have to mold the cast, dent the cast to hold that fracture reduced. So there is a chance, it could get too tight, but if you elevate it, you can't ice through a cast, but if you elevate it, it usually won't be a problem. Other times, I think a brace is better than a cast. If a fracture doesn't need to be reduced and pushed on, you probably don't need a cast. You probably could just have a brace, which you can tighten up and you won't have that problem with the cast getting loose and stinking and,
stinking
not
and
being able to
such.
take a shower and stuff.
Are you still using plaster casts, or are you doing plastic?
I do fiberglass casting, and then I use plaster for splints when I do that after like an operation. But a lot of the stuff that we use in the office is braces.
Okay. Can you add to that, Matt?
Yeah, just there's been new advances in casting. There's some casts that you can do a waterproof cast now. That's a possibility. But I think everything that Mark said is spot on.
Okay. We have an email question. Thank you for your questions. Please give us your call. It seems that elderly people who break their hips die relatively soon afterwards. And we know hip fractures carries with it, oftentimes they're falling for a reason, and sometimes that's part of the problem. But it seems that oftentimes they'll die relatively soon. Is that true or not? And what percentage of people with a hip fracture are going to die from within the next 6 months? Do you know?
Well, I think typically we say 40 to 50% within a year will pass away. The thing is you don't know who that will be, for one. So you could do a hip fracture on somebody and they could pass away that week, or they could live 5, 10 years, 15, 20 years. You really can't predict that. But the reality is even in those patients who don't live long term, it's still much better treatment because it is very painful to have a hip fracture and you just lay there. So a lot of times you'll even do it for palliative reasons.
Just for comfort.
For comfort, it's better than the pain medication will do. It allows them to at least be comfortable with their family during those last, weeks or months of life.
I always pushed our orthopedic surgeons in our community to take them to surgery. Well, my dear friend Dr. Ramsey, who worked side by side with me for so many years, would say, "Rick, this person is not going to do well." And I said, well, we can try. I think this person's going to do a little bit better than you think, and I'll get her through the surgery if you'll just do the surgery. I'll cover the rest of it. And we took care of an awful lot of very frail people that lived for a while. What percentage of them go to a nursing home afterwards? You know about that, Matt?
I think there's a good majority of them. I mean, these are elderly patients that have, once again, a lot of medical problems. They're unstable on their feet just to begin with. But then you add on the multiple comorbidities that they have, as well as the new hip fracture, and it makes it a little bit more difficult for them to get around on their own again. I would say for the elderly individual who falls, breaks their hip, they're about 70 to 80% going to a nursing home for a while, for at least 2 to 3 months.
I do know there's some data to say even if you were perfectly fine at home, living at home, stable, and you end up with a fracture, oftentimes you're going to be in the nursing home, and that's where you'll stay. So one of the things that we need to do is to try to teach people not to fall. And I would say that number one, you absolutely need to be exercising to help prevent the problems. That's just a walk. That's 20, 30-minute walk a day. A walking stick, if you feel like there's a risk of falling, it tells you where you are in space. It doesn't have to support you. You use it to tell you where you are in space. A lot of people will walk around the room and they'll find their way to the bathroom by touching things, because then it tells them, because they've lost the feeling in their feet. So a walking stick tells them, that gives you a third leg to say, okay, this is where I'm at. And I think just the idea of strengthening exercises, and the bottom line, I'm taking too much time, but I want to make this point. The most common reason for people to fall is blood pressure pills, bladder pills, and mostly blood pressure pills. And I'm treating their blood pressure is 160, 170 in my office, and they come back to me and they say, but when I stand up, I get really lightheaded. Well, it's 90. Systolic, top number 90 when they stand up. So you've got to either find a better pill that doesn't drop them, or take the risk of a higher blood pressure and not the risk of falling and fracturing your hip. Now, I just talked too long. Any comment, Mark?
No, I would agree 100% with that. We don't want to over-medicate people. We don't want to under-medicate, but it's a individual with multiple problems, and you got to balance out the blood pressure with the risk for falling, with the risk of all other kinds of things. And so I think what you're saying is spot on.
Now there's other ways of fixing or doing a total hip. People
Yes.
talking about front and back and all this. Explain that, Matt.
Sure, there's multiple different ways to get into the hip. There's been about 4 or 5 different ones that have been traditionally taught.
Right.
The newest one is called the anterior hip approach, which is nice because it is muscle sparing. In other words, the other techniques that we have been taught and that have been done in the past, you'd have to take off a muscle or take off a tendon to get into the hip to do the hip replacement. There's the new anterior hip approach where instead of taking off a muscle or taking off tendons, you can divide in between the muscle groups to get into the hip to put a new hip in. What we've found is that people are able to get up and after their hip replacement surgery up and mobilize faster and move a little bit better afterwards. At about 3 months to 4 months time, that whichever direction you have your hip replacement is all the same with motion-wise, but it's usually just they get moving a little bit better and a little bit faster with the anterior hip.
Is it a harder procedure?
It takes specialized training to do.
Okay, but why don't you always do it, Mark?
Well, again, there's different ways of doing it. There's anterior, there's posterior, there's even a newer one called a direct superior. But the reality is it's all about getting in the components in the correct position. And if you put the components in correctly, then you're going to have a great outcome. You're not going to dislocate. You're not going to have pain. Hip replacement surgery is a home run operation. It's probably one of the top 10 medical achievements that there's ever been. And it's actually a very forgiving surgery, so even when surgeons don't do it quite right, it turns out frequently pretty well. But if you do it right, really it's a 98, 99% operation barring something like an infection. That's why I want to do the robotics on those kinds of procedures like a hip replacement, because you don't get those ones that are not turning out because of poor carpentry. But at the end of the day, it's all about the bone work when it comes to a hip replacement.
Wow, carpentry. I love that word. I mean, that's kind of what you guys
That's what we do.
One of the best things one can do to prevent falls and fractures is to just move. Joining an exercise group improves not only your physical health, but your daily outlook as well.
This is what we call a healthy movement class. The goal of the program is to hopefully strengthen hips, legs, and core of elderly citizens of Brookings to try to prevent any sort of falls. We do a lot of standing leg exercises, squats, and just general core side-to-side movements. We're not doing any sort of heavy weights of any kind. They're body weight, and we don't do a whole lot of reps. So I'd say there'd be a lot more strength training and just endurance to prevent falls by strengthening hips, core, and legs. But the latent function that a lot of people might not think about is we're just generally improving lifestyle. This is another chance for the elderly community to get out, socialize, to exercise, and just live a happier lifestyle. It includes core strengthening, leg strengthening, and also some bouncing and hopping to strengthen bones and prevent any fractures, hip breaks, things along those lines. Along with just general balance techniques, eyes closed, how can you hold your balance up? And we would sometimes walk a line to see foot to foot, front to front, and that's a good way to see the improvement. That's our best way of measuring balance improvement. We have all sorts of people join this class. I know a few of them have had past injuries, but we have young, healthy people who want to get out, in a social atmosphere, and have an exercise program that's going to hopefully prevent falls in the future before they've even had an injury. Almost a form of preventative exercise. Every 4 to 5 months, we'll do a checkup, basically. We'll have everyone fill out a survey saying, what do you find difficult? What's the difficulty for you to walk a mile? What's the difficulty for you to stand up out of a chair? And we hope to see a positive trend, and we have since our first one we did was in March, and then just last month in October, we did another check, and it seemed everybody had a positive trend. If you're trying to improve your health, the best thing you can do is just try to improve your lifestyle, improve your happiness. I think one of the best ways to improve happiness and lifestyle is to get out and be active, get out and socialize. When you get out and socialize, you're likely going to have to be active doing it, and this is just a great opportunity to mix both those things. Up, 3, if you can hold it there for a moment, even better.
Well, we had a mechanical thing. I think I had one question, that was all, and I'm going, nobody's calling in questions, and it was a mechanical problem, and of course, we've got plenty of questions, so we're going to dive into them. Start with the first one. What is a hip? Is it a bone, femur, pelvis? What is it? What is the hip is the generic term? She wants to know better what a hip is. Matt?
Sure. What a hip, it consists of the top part of the thigh bone or the femur. It's the ball, but then it's also part of the pelvis as well. There's a socket in the pelvis, and then the ball at the top part of the thigh bone of the hip, and the thigh bone of the top part of the thigh bone, which is what we call the hip.
Yeah,
and
it connects to the trochanter. So the trochanter is this thick part of the top of the femur that goes down to the knee, right?
Correct.
So that the trochanter, I've often wondered, isn't that what everything attaches to, I guess, is? What does it do? I mean, it's what thing is attached to, I
That's
guess.
where the important muscles that balance your pelvis when you're walking are attached. So if you don't have hip abductors, you don't have a functioning hip.
No, there you go. I'm on Plavix, and I have been told it's very bad for me. What are your thoughts on this? My answer is Plavix is a wonderful drug. It's like aspirin, and it thins the blood, and it's important to prevent blood clotting. Any other comments? Plavix?
I'm from the other side. I hate Plavix. So
Because they bleed, don't they?
Yeah. So again, it's one of these things where it helps certain things like stroke risk, cardiac risk, and stuff. So if it's safe for a patient to not be on Plavix, because some people get put on it and they never follow up, and maybe they do need to be on it for life. Some people maybe don't need to be on it for life. But when somebody has a hip fracture, you can't reverse Plavix.
No.
So it bleeds a lot into the hip, and that's always a difficulty because you want to get in and fix the hip early, but you got the Plavix on board.
There you go. Hit a nerve during hip replacement, no longer can kick. I can pull back. Is there any way to fix the nerve, Matt?
It depends on if the nerve's pulled on or if it's completely transected.
If it was transected, it's probably
not coming back.
No, but sometimes they can come back. How long does it take for the nerve to grow from the hip down to the lower leg?
Well, teaching is about, it's a millimeter a day, so it's how many millimeters you are.
Okay, so 30 millimeters, 300 millimeters is a foot. So it's going to be 600 days to get down to the leg to see if it'll come back or not. Hip replacement on one side and knee replacement on the other side, and Dennis said, I need to take antibiotics. Is that necessary after 3 years?
So this is a very controversial area.
Yes.
I'm one of these folks that tends to err on giving a prophylactic antibiotic. I will say that is one area which is not solid in the research literature by any means, but my thoughts are is taking some amoxicillin, 2 pills an hour or 4 pills an hour before a dental procedure, if it could prevent 1 out of 1,000.
And I'm on the other side because antibiotics are overused, and if they can't prove that it makes a difference, nothing is better. See, so we disagree, but that's okay.
I'll be the tiebreaker. I agree with Dr. Merritt.
Already have one knee replacement and need the other one replaced. Surgery caused one leg to be longer than the other. Is this something they can fix when they replace the other one?
Sure. So typically when you have a knee replacement, you're taking people's bow-leggedness out, and that's making them straighter. And if they have a bowed leg on both sides, you're making one leg straighter, which is going to make somebody feel off-sided, lopsided. So when they're walking, they feel off-kilter. So if you go and you replace the other side, get the other side straight, then they even themselves out.
The answer is yes. Husband broke heel and developed arthritis in his ankle, which has immobilized him. Is there something he can do?
See a foot and ankle surgeon. That's a very difficult injury, a calcaneus fracture, which is what the heel bone is, and that's really specialized and really, you can
It's a
look
real
at
challenging area,
difficult.
boy, tough. Doesn't always work, does it?
No.
A friend in pain with her hip and was told it's arthritis, but didn't recommend anything. What can she do for it? Arthritis is a big issue. We could have talked all night on arthritis, man.
Quick treatments for arthritis. For the hip, weight loss is great for it. For every pound you lose, your hip sees multiple pounds off of it. Anti-inflammatory medications, you can do hip injections, hip replacement surgeries.
People talk about new cartilage replacement. What is that?
New cartilage replacement. There's different surgeries, maybe not for the hip, but for other joints.
Other joints.
Other
Mostly
joints.
the knee?
Mostly the knee, some of the shoulder, where you can go in and you can take a piece of their cartilage, take it out, grow that up into in the lab again, and then put that back in.
So you're transplanting their own cartilage. You kind of just spray it in there and it kind of takes it up, or how does that?
The new technique is, you used to have to sew this cartilage back in, which was laborious. It was very difficult and hard. They have a new technique where you can just put it in by basically glue. It's like gluing a stamp.
How long are hip replacements good for, Mark?
At this point in time, if the hip's done well, that's the most important thing, and then you don't fall and have some kind of injury. I mean, a hip should be able to last you 25 years.
25. And if you're 90, you're probably going to last a lifetime. What is the percentage of people who fall and break hip versus people who break their hip and then fall? Some people talk. I had one patient who knew when she twisted, it broke and she went to the ground. I know that happened. What is the percentages, you know?
I don't know the percentage, but I know that the majority is they fall and it breaks.
You do see those twists, though, of the femur. I mean, they have this...
spiral kind of component to it, yes.
And some people have congenital cysts and so on, and their bone is weaker in another spot, so sometimes it happens that way,
Yeah,
too.
I think if it happens spontaneously, you just have to make sure that there isn't like a tumor or something like that.
Yeah. How often and is it common for bones in people's feet to break while walking? Feet fracture when walking, not falling, just walking. Either one of you.
If you're a high-level runner that runs all the time, you can easily get stress fractures and have a broken foot that way. Or I think the other time that we really see it is somebody who has really poor bone health. In other words, they have osteoporosis.
They haven't been walking all their life. Now
Correct.
they're
Now
trying,
they're trying to get into it, and then it breaks.
And really the answer right there is never stop walking. Get into at least 30 minutes of walking a day. They say 31% reduction in death rate if you walk a mile a day. If you go up to 3 miles, it's 39%. So you get 8% more with that extra 2 miles. It's that first mile that matters. How often, the use of Fosamax is a prevention. Many side effects, is it really of great benefit? Mark?
I think it's of benefit. The bisphosphonates help a lot in reducing the continued loss of bone density. It doesn't necessarily reverse bone loss, but it can maintain it so it doesn't get any lower. There are some potential spontaneous fractures that can occur as a result of it. There's other things like causing problems in your jaw. And so there's no medication without potential side effects.
And personally, I don't prescribe it, haven't ever really, because it doesn't hold a candle to walking.
Right.
And we don't really know the long term. Now we found, 10 years we got fractures. Forget about it. Walk. Do you not recommend calcium or magnesium supplements? That's a good question. I've got my opinion, Matt.
I love calcium supplements. I usually tell everybody calcium and vitamin D just for good bone health.
Okay, and you're in agreement.
Yeah, I mean, you need a balanced diet. I think that's the most important thing. And then making sure that you have enough active vitamin D, which a lot of times is not just your diet, but sunlight and things like that.
Although there's new data, here's what I would say. And this is an internist, right? Calcium supplements look like they may increase vascular problems with people, and that really the problem is vitamin D, and the very best source of calcium is food. So my sense is I've stopped prescribing. I mean, I used to push it like crazy. I'm not pushing it anymore. I push vitamin D because there it is. Broke my hip when I was 65 3 years ago, recently fractured my knee, just started walking again and have had terrible groin pain. Nobody can explain the pain.
Groin pain, you got to look at the hip joint. That's the most common presentation for hip problems. So looking for arthritis. If it's the same hip, you could have post-traumatic arthritis. If it's the other hip, it could just be regular degenerative arthritis. But look at the hip.
Okay, how about the vascular compromise during the hip pinning? I mean, now he had hip, broke my hip, so I'm sure had surgery. My guess is they did a hip pinning. Sometimes they lose the blood supply to the hip, and then 6 months later they end up with arthritis, and it's because they lost. What is that?
You have one major artery that goes up to the hip that supplies the ball of the hip. Sometimes when you fracture your hip, it actually tears that blood vessel. And because that blood vessel is not there, the bone can't get any blood supply. And like anything, if you don't have any blood supply, it goes, it dies. So you can't have death of the ball of the hip.
Isn't there a little blood vessel that comes from the pelvis out to the hip? I mean, I remember that, but I don't
The
remember
obturator artery, it's very small.
Yes.
It doesn't have enough blood supply to supply the whole hip. It supplies just a piece of that ball of the hip.
Osteoporosis and arthritis in the hip, is there any herbal remedies or supplements for the pain? Mark?
For the pain, I mean, a lot of times people are taking fish oil and turmeric and things like that from an herbal standpoint to try to reduce inflammation in their body.
There's a lot of these other things, but I like Aspercreme rubbed on. I mean, that's a supplemental kind of a thing. It smells really good. You get someone to rub it. There's a lot of help. We've got 30 seconds more. Need surgery for shoulder. Been getting shots. Should I continue with shots or get surgery? I'm worried about my dominant arm. What point switch from shots? Matt?
Depends on what type of surgery you're going to get. I think that if you're going to have it, though, it's going to be when you say it is, when you say it's ready, when you are ready for it, when you say, I can't deal with the shots anymore, I'm tired of doing the shots, it's time to do something.
All right. And now for the winner of tonight's Prairie Doc Quiz question. List 3 different types of medicines whose effects might increase an elderly person's chance of falling. Well, blood pressure medicines, bladder pills, sleeping pills, anti-anxiety pills, major tranquilizers, sedating antihistamines like Benadryl, opioids, you know, the narcotics, for a partial list. Now that was 7, we only needed 3, and it was Carlton Retzlaff who answered the question correctly. Thank you, Carlton. And a book will be in the mail to you soon. We'll be right back after this.
On call with the Prairie Doc is very important to a lot of people in this area and in this region because it communicates a lot of very valuable information on healthcare, medical issues, answers specific questions. This project takes dollars. We have people in studios and we have people that have to be paid and we have to do production costs, even though Dr. Holm's time, our time, the guest time is all donated, we still have production costs. We have a great foundation called the Healing Words Foundation that oversees this whole operation and is responsible for some of the fundraising to promote these programs. If you like this program and you enjoy the information you're getting and you find it's valuable, please feel free to go to our website and donate. We would really like to have some additional financial support, and it's very simple to do. And again, it'll keep this program going for the foreseeable future. So the website is prairiedoc.org, O-R-G, prairiedoc.org. Go there, donate if you're so inclined, and we thank you very much.
Thinking about bone fractures brings up an old English children's rhyme. Sticks and stones may break my bones, but words will never hurt me. This ancient phrase has supplied many a verbally abused child with clever words in defense from a bully. I wonder if this old saying had an interesting history, but found nothing about its early beginnings on the internet. The first written record of the phrase was in an English book authored in 1830 with the words golden sticks and stones. Later in 1862, the words that are used now popped up in a U.S. magazine printed by the African Methodist Episcopal Church. Close to 15 million fractures occur yearly in the United States from various causes, mostly from falling, more rarely from sticks and stones. It's intriguing to examine how a fractured bone heals. When a single bone breaks, there becomes 2 parts with rough edges of the fracture held loosely together by muscle and soft tissue. Bleeding into the fracture site is a necessary step for healing since the blood clot that forms around the break initiates inflammation, redness, pain, swelling, and heat. Inflammation tells the body to avoid movement, stimulates new blood vessels to increase blood flow to the area, and calls in white blood cells to fight infection and clean up destroyed tissue and cells. Over the first week or 2 after the fracture, stem cells are drawn in to help. They turn into cartilage-making cells and replace the blood clot with an early and soft cartilage. This material is sticky, and if the bones are not yet reconnected, the gummy and adhesive cartilage helps them rejoin and then binds the bones together. This soft callus hardens over the next couple weeks, stem cells turn into bone-making cells, and new bone tissue starts filling in. Given proper nutrition, immobilization of the fracture, and enough time, bones will completely heal, even in very old persons. I believe it's a slow and constant miracle how our bodies are always and everywhere healing, repairing, and even replacing themselves from birth unto death. Back to the children's rhyme, Sticks and Stones. Isn't it true that sometimes hurtful words cause broken hearts that never mend? Perhaps we should learn from the grace and speed of healing bones and let go of those hurtful words, forgive, reconcile, and heal. Didn't get to all your questions, so we're going to go to Facebook right after this show and we'll answer the 8 more questions we got. We'll answer those then. A big thank you to our guests, Dr. Mark Mayer and Dr. Matthew Blake, for volunteering and joining us in the studio in the Yeager Media Center at SDSU. Thank you. Their experience brought great insights to our table tonight. And another note, on April 28th from 9 to 12 at the Mother Butler Center in Rapid City, there will be a free spring empowerment conference by the Fully Alive South Dakota organization. Pre-registration is required. For more information, go to Fully Alive South Dakota Facebook page. Again, we didn't have enough time to get to all of your great questions, and our audience needs to know that we're trying to do that. If you would like to hear the answers to those questions, join us on our Facebook page as we continue, and our website with Prairie Doc After Hours. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people. And now,
glaucoma, cataracts, macular degeneration. As we age, our eyes can be the target of many problems. Eye conditions of the elderly. Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions: Brookings Health System, Ophthalmology Limited, American Academy of Family Physicians Foundation, and South Dakota Academy of Family Physicians, the Avera Heart Hospital, Dakota Allergy and Asthma, CoBank, Fishback Financial Corporation, Vance Thompson Vision, Aberdeen District Medical Society, Black Hills Medical Society, 3rd District Medical Society, Brookings, Madison, and Flandreau, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and SwiftTel Communications.